we are live in 5, 4, 3, 2, 1. We are live now.
A very good evening, ladies and gentlemen. This is Dr. Harsh Chaturvedi from Pulse Pharmaceuticals, welcoming you to a very exciting evening, which involves deliberation between Dr. Naresh Shetty and Dr. Raju Easwaran, with the emphasis on the role of acetaminophen in managing chronic pain with comorbid conditions. I'm sure you have seen a whole lot of chronic pain, and you have realized how problematic it is to treat, even with a wide array of medicines and the procedures which have come up over the past few decades. We understand that acute pain, well, it is much easier. It is more of a symptom of a disease or a trauma, and we have been able to. But whenever it comes to chronic pain, which we consider as a disease in itself, it's a tough ask, and we know it is quite disabling, and it has a significant impact on health, social, and economic repercussions. Add to pain, somewhere the psychiatric comorbidities are there, behavioral issues are there. Most of the patients with chronic pain, they have conditions like diabetes, they may have hypertension, and so on and so forth. So therefore, somewhere the usage of drugs is also restricted, whether it's NSAIDs. Opioids are always a dilemma. We understand the emergence of probably gabapentinoids somewhere has helped us, but still pain remains inadequately treated. And I believe in our country, about 36% of the population at least suffers from chronic pain. And this could be a very conservative estimate. I believe both Dr. Shetty and Dr. Easwaran would be seeing much higher numbers in their practice. And therefore, it is of paramount concern to us that how and effectively and safely the chronic pain can be managed. The intention also is to highlight not only the efficacy, but the safety profile of paracetamol. We know the usage of NSAIDs is fraught with renal issues, it's fraught with gastric issues, dependence with opioids. When we talk about gabapentinoids, somewhere it's a toss-up between sedation and giddiness. So one has to choose between the two, whether we're talking about pregabalin or gabapentin, and so on and so forth. And after the procedure, many a times the patient still cries of pain and has had inadequate relief. So to make us understand the usefulness of the drug, which is at the very first step, if I look at the step-ladder approach for the treatment of chronic pain, acetaminophen. We have both the experts with us. And before I hand it over the program, which, ladies and gentlemen, will be a sort of a dialogue between the two, with the slides running. So it's like a tete-a-tete that we are going to have between Dr. Shetty and Dr. Easwaran. I'll take this opportunity, though both of them do not require any introduction to this audience, but still I take a liberty of reading out a few words about both of them. And also would like to, sorry, I think I pressed, and also would like to talk a bit about my organization before we go on to the presentations. I hope my slide is visible.
Yes, it is.
Yeah. So, ladies and gentlemen, I again welcome you to this program this evening to reinvent the real potential of acetaminophen in chronic pain, how and why. And as I mentioned, we have Dr. Naresh Shetty, who is ex-president International Program of Strategic Alliance at Ramaiah Memorial Hospital. He has 21 years of experience in orthopedic surgery, trauma, and arthroplasty. Dr. Shetty is a former medical director at MS Ramaiah Medical Teaching Hospital and also a former medical director of Ramaiah Memorial Hospital. He has conducted hands-on workshops in external fixation. Dr. Shetty is a recipient of International Youth Exchange Program, which was awarded by Rotary International. He has been recipient of Best Papers Award in Karnataka Orthopaedic Conference in 2001 and 2004, and had organized international workshop on arthroscopy and total heel replacement at Bagh. With these words, I welcome you, Dr. Shetty, to this today's deliberations. Ladies and gentlemen, we also have Dr. Raju Easwaran with us, who is director of Shree Menakshi Orthopedics and Sports Medicine Clinic at Shalimar, Bagh, New Delhi. He is also principal consultant for Arthroscopic Surgery and Sports Injury Unit, Max Super Specialty Hospital at Shalimar, Bagh, New Delhi. He is the present treasurer of Society of Knee Surgeons in India, ex-member of ISACOS newsletter editorial board. He is a charter member, club trainer, and IT in charge of Rotary Club for the Elites. He is a past executive committee member of Indian Arthroscopy Society. He has been a recipient of Best Paper Award for minimally invasive fixation of PCL bony avulsions at the annual conference of Delhi Orthopaedic Association, and is a recipient of Best Postgraduate Student Award at MAMC, Maulana Azad Medical College, New Delhi. With these words, I welcome Dr. Raju Easwaran to this evening's program. And before I hand it over to them, I'll briefly talk about my organization, which is Pulse Pharmaceuticals Private Limited. We are a patient-centric, innovation-driven, integrated pharmaceutical company with an inclusive growth model. We have our own research setups, we have our own manufacturing facilities, and we also have our marketing teams. We have been active for past 26 years across India and emerging markets. With our we have world-class R&D and manufacturing infrastructure, which is spread over the state of Telangana and Uttarakhand. We have strong leadership teams and operational teams across all business functions. We operate with 7 divisions, including the international business. We lead in the space of nanopharmaceuticals and drug delivery research. We have strong presence in medical nutrition through Pulse NutriScience, and we are foraying in immunocell therapeutics by developing novel CAR-T technologies. For this, we are collaborating with none other than Center for Cellular and Molecular Biology, which is based at Hyderabad. Our business philosophy is to create customer value through high-quality differentiated products and services by using advanced technologies. Some of the products which are already there in the market include Dixil, the vitamin D formulation. We have now Nexpar, which also makes use of our patented technologies. It provides us with a crystal clear liquid solution, which we are going to be introducing shortly. Now Nexpar LA and a few other products which are very differentiated from what we have in the market. This all comes out of our research and manufacturing infrastructure, which is based at Genome Valley, Hyderabad. We have Pulse Advanced Research Center based at Hyderabad, Pulse NutriScience R&D and Manufacturing Center again at Genome Valley. And we have new facilities coming up at our other places. And apart from the existing facilities at Roorkee and Shyam, close to Hyderabad. Nexpar LA is what is one of the recent introduction for chronic pain. It is acetaminophen bilayered 1000 milligram tablet, which helps us to give a BID dosing rather than the QID dosing. It is a small size tablet, which is easier to swallow, especially in the geriatric population. It is safe and effective in chronic pain management. And it does give us adequate concentrations to provide adequate relief continuously from the pain. With these, finally, we have been recipient of a Udyog Bharati Award, the Hall of Fame Award, the National Award for Quality Excellence, and the India's Small Giant Indian SME Forum Association with NDTV in 2018. These are some of the awards that and accolades that we have received over our existence of past 26 years. And with these words, I thank you very much for listening to me, and I hand over the program to Dr. Shetty and Dr. Raju Easwaran to take us through case studies and the role of acetaminophen in chronic pain with comorbid conditions. It is over to you, Dr. Raju Easwaran.
Thank you very much. I'll just request if my screen is visible, just an acknowledgement if the screen is visible.
Yes.
Wonderful. So I'd like to begin by thanking Dr. Naresh Shetty for letting me lead the discussion. But as Dr. Harsh mentioned, that it is going to be a kind of a dialogue. And this is something which we plan to conduct in a very discussion kind of a way so that we all can derive the maximum out of it. Now, one of the impediments, I think, in the mind of both patients and surgeons to prescribe a molecule like paracetamol, I'll begin by narrating a small story that I encountered during my hip fellowship with Professor Michael Dienst in Munich. One very high-profile patient visited him from Dubai, and he was expecting some very hi-fi treatment from Professor Dienst for his hip condition. And all Professor Dienst said was, I think you should take paracetamol and exercise, and he felt bitterly disappointed. So that's sometimes the reaction that our patients give when we prescribe molecules like paracetamol. But regardless of whatever fancy molecule we may have at our disposal, we know from practical experience that everything comes at a cost. And the cost, when we are speaking of most NSAIDs, are cost in terms of GI complications, renal complications, and cardiac complications. And these are in a set of patients who are elderly, who have knee arthritis, who have chronic back pain, and other chronic pain conditions, who are diabetic and who may have some multiple other comorbidities, which we as orthopedic surgeons probably are slightly less well equipped to deal. So I think in this scenario, particularly in a country like ours, where we have a lot of diabetic patients who have a compromised renal function, the role of a molecule like acetaminophen is even more important. And now with the availability of sustained release acetaminophen, probably it sets the right stage for discussion. And as surgeons, we obviously like to operate and restore anatomy. I'm not going to pretend that I understand the molecular structure which is shown in this diagram. It is just to fill the space. But then paracetamol chemically is N-acetyl para-aminophenol, or acetaminophen was marketed as Tylenol, I think, in America way back in the 1970s or 1980s. It is the commonest over-the-counter drug worldwide, and therefore it might be logical to assume that we know a lot about how paracetamol acts. So I would just like to take Dr. Shetty into the discussion. Paracetamol is grouped under NSAIDs. And that is probably because it has activity against cyclooxygenase. But Dr. Shetty, sir, with your wide experience of both treating osteoarthritis and rheumatoid arthritis, inflammatory and non-inflammatory arthritis, what are your observations regarding the use of this molecule in these conditions, sir?
I think, Easwaran, we have gone through a story of NSAID, COX-1, COX-2, and so on and so forth. We have seen in our age, a lot of things are coming. It was sold as the next best treatment that's available for mankind. And then after a couple of years, you see a lot of complication coming in, and the drug is thrown out of the window. So I think there is certain things that keeps on happening. And I think during our own lifetime, you see many of these things happening. And so the story is always learn, unlearn, and relearn. But during all these stories, certain molecules like paracetamol have remained with us, whether we like it or not. But the beauty of this particular drug is still not much is known about how does it really act. And I think, Easwaran, you would also agree that there is no real document that said, how does it really act to ensure that pain is relieved, and on what is the basis behind that? Though all of us use it, and I think that in many a condition, I've been using it. Of course, there's a lot of misuse also, a lot of over-the-counter sales that is happening. And many a time, I think there's a duplication of this particular drug being utilized for a variety of activities. And so many a times, the untold story about a drug is a classical story of, I think, paracetamol. But as we have come that paracetamol suddenly got into this thing with COVID, it came into highlight so that now everyone thinks that one particular brand is only meant for COVID and nothing else. So the story keeps on changing. But the biggest problem of all of us, between me, Raju, or the many of us surgeons that we have practiced, is how much paracetamol do we give it for a patient, and how effective is has been the story. So I think if at all what Lancet has talked about way back in 2003, we still are not very sure till today, though there are a lot of research that has gone across. And I think there are certain articles that are available now which says that paracetamol probably is the best drug in a given situation, especially in mild cases of osteoarthritis and mild back, or is the first line of defense in this management of chronic pains.
True, sir. And the fact that paracetamol has no antiplatelet and GI effects probably place it above NSAIDs, at least in my practice profile, when I see an elderly patient with a chronic pain like osteoarthritis, who I know is probably going to need some pain relief molecule almost on a daily basis until they decide to get a joint replacement done. And you would know, as being an experienced joint replacement surgeon, that patients require these molecules for a certain length of time, even after joint replacement. It's interesting that around the year 1971, when cyclooxygenase was discovered, the person who discovered it, I forgot his name, I think Helen, he actually got the Nobel Prize. And that's when he clubbed paracetamol with other NSAIDs like aspirin, etc. That was a time when aspirin was being less and less popular, because especially in the pediatric population, it tended to cause Rees syndrome. And that's when paracetamol shot up in popularity and has been used thence. Sir, I would like to know your experience with these COX-2 antagonists, which were suddenly thrust at us somewhere around 1990s as the panacea for GI problems. What has been your practical experience in terms of the pain relief that they afford compared to the non-selective COX inhibitors, and any side effects that you have observed in your practice?
Actually, I think a lot of times the company also sells so well to us that only as an afterthought we start realizing what are the issues that keep on coming. And I think most of us, initially, we were sold by the fact that there's hardly any gastric intolerance. And so we did not look at the other side effects till it became very, very relevant that it had a lot of cardiac side effects. And then very soon they went out of the market. So I think the story, the untold story, or the story told, has been the same. It came, it made an impact, and then suddenly it was lost. That's the story, I think. And I think a lot of our patients did suffer through that. So I think, like orthopedic surgeon, most of the time, we just give painkillers. And the people who benefited were the people either in gastroenterology group of people, or probably the nephrologist group of people, or the cardiac group of people, I think, benefited, or we ensured that the patient reached them. Thanks to our ignorance.
And so did you also feel in your practice that these COX-2 antagonists are less effective or less analgesic compared to the non-selective? For example, for your acute post-op, would you rather prefer a COX-2 inhibitor or an agent like, let's say, ketorolac, which is a non-selective COX inhibitor, or diclofenac, for example?
So basically, most of the time I have been I think we have been using injection paracetamol as a primary drug, basically because most of our patients were elderly with multiple comorbid conditions. So I think, so that was been thing. And now I think with good analgesia and good anesthesia that we give, the post-op care has been taken most by the anesthetists for the first 48 to 70 hours by the epidural injection. So I think we stick to that more often than giving them any kind of this COX inhibitor.
And it's only very recently that some light has been shed, and this is actually a group of researchers led by a South Indian, I think Dr. Venugopal from Stanford University, who actually discovered COX-3, a variant of the cyclooxygenase receptor in the brain. And it is interesting that in therapeutic doses of paracetamol, it was found to have a stimulatory effect on the brain, but in toxic doses, which we will discuss later, apart from liver toxicity, paracetamol is also found to have toxicity on the brain. So it is now believed that the paracetamol primarily acts centrally, since it can freely cross the blood-brain barrier. And since it has a very high volume of distribution, the volume of distribution of paracetamol is nearly 50 liters. What it simply means that if you take paracetamol, it will very quickly go to almost every portion of your body, right from the occipital lobe to the cell in the little toe. So it has very little binding to plasma proteins as well. So that makes it a very good molecule for a very quick reach to various areas of the tissue. And recently, one of the metabolites of paracetamol has also been identified to activate the cannabinoid system. So despite the fact that we have this molecule for nearly half a century, we are only now very slowly beginning to understand how it actually works. Now, when it comes to dosing and frequency, sir, what has been in your practical experience the commonest problem with the standard paracetamol, let's say the 650 milligram strength that we prescribe? What has been your most common issue that your patients have come to you with?
The biggest problem is that since the frequency of this particular medication has to be at least 4 times to be given, the compliance is one of the major issue that is there. And you know how patients are, whenever you tell them to take tablets on a regular pattern, till the time 1 or 2 days they'll take. And the biggest problem for all chronic patients is how do you ensure that the compliance from the patient is good enough to get the best possible result. And for that, I think there's only way is to ensure that the frequency are reduced so that they are more compliant.
Very true, sir. I mean, it's almost like a patient is on a meal of paracetamol to take a tablet 4 times a day. I'm sure all of us have discovered in the pandemic, all of us have been affected by the pandemic directly or indirectly, and taking even 2 or 3 doses of paracetamol, at least I felt that it's a major interference in my life when the fever struck me. And the problem with the 650 milligram dose, at least that what I practically observed when I got fever, is that once the fever starts, you have to actually suffer in misery for half an hour to 1 hour before the blood levels of paracetamol rise to the therapeutic level, which is roughly the same for both analgesia and antipyresis, 3 to 5 micrograms per mil. And then no sooner than you've gotten relief from the fever, you're back to square one. So I, at that point in time, was actually looking for a molecule which can probably maintain this for a steady state. And that's when I was prescribed mefenamic acid by my pulmonologist. Now, when it comes to safety profile of paracetamol per se, as long as it is consumed in the therapeutic dose, and it's a big if, it's a very safe molecule. In pediatric, 150 milligram per kilogram is the maximum upward limit of paracetamol that one can prescribe. In adults, it is 4 grams per day. That's getting probably readjusted to 3 grams per day based on a very recent US FDA recommendation. But sir, I would like to know your inputs about the second point that I just put up. A lot of our patients will have some problem or the other, some allergy, seasonal allergy, flu, etc. Now, these medicines also contain paracetamol, and I think everything adds up. So I feel that patient education, even though it's not our primary specialty, but it probably forms a part of our responsibility to tell them about this, sir.
Without a doubt, it's an obligation that we need to ensure, because most of the time, most of our patients take some drugs from some medical store. And so when we start giving paracetamol, they would have already have some medication which has got already paracetamol along with it. And I think that, I think in America, US, they have made it that you cannot have in a combination dose paracetamol more than 325 milligrams.
Very true, sir. Very true. So the 2014 FDA resolution. Very true,
yes,
sir.
They said you can't have anything more than 325 because they were looking at multiplicity of the medication that has been taken by patients. And then at the end of the day, a lot of people had more than 4 grams they used to do without ever realizing. And as a good clinician, I think it is our duty to ask the patient what are the other medication they are in. And even if the patient doesn't want to let you know, it is better to ask them as a leading question, because I think at the end of the day, we are obligated towards this patient, and that's what I think we should all do.
True, sir. And I think as orthopedic surgeons, probably we give a lot of undue attention to things we love, like operating. And perhaps we spend less time studying the side effects of the drugs we prescribe, particularly the interactions with the comorbid medical conditions that our patients may have. And that's the reason why I put up the next point in this slide. It is important to know that while 85% of paracetamol is safely metabolized, 5 to 15% of paracetamol is actually acted upon by a separate enzyme in the liver, the cytochrome P450 system. And it is metabolized to a molecule which has a very long name, but let's just call it NAPQ1. Now, NAPQ1 as such is destroyed in the liver by a compound called glutathione. But glutathione, like an orthopedic surgeon's attention span, is a limited reserve. The liver only has a certain amount of glutathione, and if you have an acute overdose or a chronic overdose of paracetamol, this NAPQ1 is not neutralized by glutathione, and it directly covalently acts on the liver cells. So this is one very unique side effect of paracetamol, which we probably should make aware of the orthopedic community. Even though it is paradoxical that a patient with a liver problem can still be prescribed paracetamol, but it is best done by a hepatologist or a gastroenterologist, and it is best done in a much reduced dose of, let's say, not more than 1 gram, or at the most not more than 2 grams per day. Sir, I would request your comments on this.
Yeah, I think very, very true. I think in our role of ensuring trying getting a very safe drug for pain, and which is our primary intention. And as orthopedic surgeon, knowing less of physiology, more of anatomy, many times we fail to understand the pharmacology of your drug. One thing is very clear, and I think we must make it between me and Easwaran, we want to make it very clear that if at all a patient has got any liver issue, I think we should talk to them and talk about saying that this drug should not be used in a liver issues. But it's quite safe wherever there's a cardiac issue, wherever there's a renal issue, or where there's a gastric intolerance. I think these are quite safe drugs. But I think hepatotoxic, this drug should be very, very be careful about.
True, sir. And we will probably re-emphasize it. And it is a very highly recommended molecule in orthopedics. So, sir, I would like to hear your experience as a senior clinician. You get a patient, a typical patient with knee osteoarthritis, an elderly person complaining of pain. Apart from the usual workup, X-rays, MRI, etc., what is your usual prescription in terms of molecule for pain? What is your preferred molecule that you prescribe for pain?
So basically, I am one of those conventional persons. So when I have a patient like today, I have seen quite a few. I mean, most of the patients that walk in, and Indian geriatric group is either back pain or osteoarthritis knee, and especially the ladies in osteoarthritis knee. So basically, based on the comorbid condition of these patients, many a times I take a call what needs to be given. Fortunately, unfortunately, most of these people would have been taking some medication or other from many of our colleagues at different kinds of things. And so whenever you talk to them, you feel, so I've taken this, I've taken that, and I've taken all kinds of things. That's what they tell us. So I think one of the things that I recommend is anything which is sustained release and anything which needs to be taken once a day. Yes. Preferably at night when they do not have to take any other medication, is the way I look at it. And many times I have recommended for a patient naproxen, I mean, which is available as a sustained release. Yes. I do that in quite a number of patients that are there. To patients with a little more acute pain, I do tell them to take up along with the paracetamol as a part of an issue, because we did not have a paracetamol which could be recommended, which could be compliant. That's what we're saying, because 4 times a day, we know that patient wouldn't take it, and it's not really possible for the patient to take it also. So at the moment, and that was one of the things that I kept on saying is there a drug that we can give which is safe, which could be given frequency much less, and more important than that, patient would be compliant. I think this is what we attribute which we are looking for. And I do use naproxen, I do use diclofenac, I do acetaminophen without a doubt, different things. That is thing. And I also do sometimes I use tramadol with paracetamol as a part of this, basically looking at what are the comorbid conditions. But a standard format, yes, one of my favorite drugs still has been the time-tested naproxen. I do not know, Easwaran, how much you use it, but I use it quite a lot.
I also use it, sir. But then I would just, this is a slightly busy slide, but the emphasis that this slide lays upon is that most reputed guideline generators have recommended paracetamol, and this is across orthopedics and rheumatology. They have recommended paracetamol as the first molecule to go to. And I would like to understand your perspective. So I'll tell you my practice setting in Delhi. I mean, in different parts of India, people have different personalities. Delhi probably is a bit more pomp and show, and patients get a little bit disappointed when I write a molecule like paracetamol, because they, like the gentleman who visited Professor Dienst from Dubai, expect some fancy or flamboyant molecule to be written on the doctor's prescription. You obviously are in Bangalore, much more educated and IT aware population, people who have probably traveled abroad more often, and probably they have experienced paracetamol as their go-to molecule for any kind of pain abroad. So what is your perspective on this? Are there any cultural differences or any cultural resistance to a molecule like paracetamol?
No, I think it takes time for us to make them understand. That's the biggest thing. And we as clinician, when the next patient is waiting, the next fellow will be ready to go. So I think that extra time that we need to do is to align the patient on why we are telling. I think once you tell them, they're all on board. We have no issues at all. Even today, I was talking to a couple of patients where I put them on 3 times of paracetamol 500. They're willing to take, and I did explain to them that this is not only for fever, but it also works as. Then they'll say, "Oh yeah, last time when I had fever and headache, it was a good drug." So I think this cultural change that is required is possible. We need to take an extra 2 minutes to educate them.
Very true, sir. And I'll give you an example from today's clinic. A senior scientist consulted me, and he is a well-read person. He has contributed significantly to progress of science in our country. And he said that he just wants something better than normal paracetamol. Some preparation, if he says, which has been newly discovered, or something which is an extended release kind of a paracetamol. He specifically asked me this leading question today.
Oh, very good. Yeah. So that's a good story to start with, actually, because I think I also feel that we need to have something which is probably more frequently. The frequency should be reduced. That's what we're looking for.
So that is
acting on a long term.
Biggest problem with this molecule is the 4 times a day. And I think that's where technology comes to our rescue. The extended release, the advantage that it gives is that it maintains the plasma level of the paracetamol at 3 to 5 mcg per ml. And for some reason, I think it's the technology behind the pill. Even the instant release form of paracetamol in this particular pill maintains the steady state for a longer duration of time. A normal paracetamol pill will maintain it for 4 hours, but this probably maintains it for 6 to 8 hours, and then the sustained release preparation comes in. And the biggest advantage is that it comes with the convenience of twice-a-day dosing. So you know that if your patient is probably on a polypharmacy, on a sore throat or some other over-the-counter medication, and if that also contains paracetamol, probably you're quite good, because 2 grams is going through this. And since after the FDA ruling, I think the Indian drug controller has also followed the same recommendations, and you'll probably not find more than 325 milligrams of paracetamol in any combination pill. And therefore, there is much less chances of toxicity. So, sir, I would like your perspective on the extended release molecule. Are these the 3 advantages you are also looking at, or is there anything else that you would want?
Oh, yes. I think we would love to these 3 points that you have looked at. I think they are the ones that we are looking at it. What all of us is to see the safety profile of any drug, number 1, and that we talk about the toxicity being less. All of us know that most of our patients have multiple comorbid conditions, and we are looking for, again, a drug which is useful. And most of these people already have taken so many drugs. So the less number of the convenience twice a day dosing is an ideal combination for these medications to be given for these patients. And I think one of the major problem of paracetamol was the 4 to 6 hours of the life cycle of that. And that has been taken care of by a steady dose that comes subsequently. I think that's the way to go. And more important than that, the amount of dosage is also much less than the prescribed dangerous dosage that we are talking about, 4 grams.
And from my perspective, I mean, as a consumer of paracetamol for multiple episodes of fever in the past pandemic, I would probably like to see a tablet which is easier to swallow. I mean, a smaller tablet. And I think the extended release preparation will allow some potential to compress the tablet into a more easily swallowable entity. And I think there's literature, published literature, that it is at least non-inferior to the current preparation of paracetamol that we are used to. But of course, only time will tell. This is just, I think, pre-market research which establishes non-inferiority. So with your permission, sir, I think let's summarize this session. Let's close this session so that we can take more questions from the audience. This is the summary slide that I prepared with the appropriate color coding. I think it is very important for us to give the message to our community that probably we as orthopedic surgeons should either not use it or use it very, very cautiously in patients with liver diseases. So your comments on this, please.
Yeah, I think so. I think we did talk about it. I think the reason is the take-home message must be very, very clear to our colleagues. Number one, who are desperate to ensure that they get a good drug and they know which of the patients to avoid for. And I think, as rightly said, we will avoid it as much as possible in any liver condition.
And if you have to give, I'm sure in your friend circle, you will have a gastroenterologist or a hepatologist as a friend. Keep him or her in the loop and do not exceed 2 grams per day. But if your patient is on dialysis, if he has any diabetes with a chronic renal disease, you can probably relax and give this molecule. It is renal safe. If your patient is a peptic ulcer, it is a GI safe medicine as well. The biggest advantage is that if you suddenly want to do a knee replacement tomorrow, or if the patient falls down and requires a bipolar hemiarthroplasty, it has no effect on platelets. So you can stop worrying about that. So in summary, do not exceed 4 grams per day or 150 milligrams per kilogram in a pediatric case. Keep it even lower than this. Do not try to exceed 3 grams per day. And I think with this extended release, probably we don't need to exceed 2 grams per day. Because sometimes it may feel that with 4 tablets of paracetamol, the patient is actually on a diet of pills. So the extended release preparation, at least to our minds, provides convenience of half the dose, both in numbers as well as in frequency. You only need to give 2 grams and you only need to give it twice a day. And we can probably safely say, sir, with your inputs and your concurrence, it can probably be considered in most chronic OPD pain scenarios. Sir, your views on this, sir?
I think you summed it up totally, that I don't have any words to add into it. So most of the chronic, the condition, 2 major conditions that comes are the chronic back pain and the chronic knee pain. And I think for both this thing would be an idea. To sum up, if at all that we have any kind of drug that can take care of it, which is safe, I think the first line, even in the studies that have been done, is that the first line of treatment could be a paracetamol for us. And with the convenient dosage, it can't be anything better than this.
Right. So with your permission, I'd like to end the presentation and open the floor for discussion. And I will be keenly looking forward to this molecule being more widely available to us in our local pharmacies.
Thank you, Professor Shetty, and thank you, Dr. Easwaran, for a very succinct deliberation on the importance of acetaminophen in the management of chronic pain. I have missed out during opening session. Ladies and gentlemen, you will pardon me, but I need to play a small video clipping for you, which gives you a better perspective of my organization and then subsequently we will be taking questions from you. Both Dr. Shetty and Dr. Easwaran are there to respond to this. Can I have the video, please?
The audio is not heard.
The audio is not there, Soumya. You need to run it again.
Pulse, a true reflection of the heart and its functioning. A heart that is compassionate about others and passionate about its work. A heart that is dynamic yet consistent. A heart that is predictable and reliable. A heart that goes the extra mile to deliver what is expected. Our business philosophy encompasses these very principles. At Pulse Pharma, we feel patients' problems, think, innovate, and do everything that it takes to deliver cost-effective solutions. We have a well-aligned leadership team and a highly motivated functional team to carry out our mission. We innovate and develop products with unique functional characteristics that help us serve our customers' needs better. We develop innovative business processes that help us improve our efficiency and customer experience. We have world-class infrastructure that includes an integrated R&D center and 3 manufacturing facilities that help us develop and manufacture high-quality differentiated products. Our research efforts are focused on developing nanotherapeutics, nutri-therapeutics, and cell therapeutics. Our operational presence is spread across India and 40 countries worldwide. We reach out to nearly 250,000 healthcare professionals in various specialties through our sales team of over 1,000 people and our partner sales force in various countries. At Pulse, we work with a real spirit of Pulse to bring about a positive difference in millions of lives. Because we are compassionate about people and passionate about our work. Pulse, a true
Thank you, Ramaiah, for playing this video. Ladies and gentlemen, the session is open to you. You heard the views of Dr. Shetty and Dr. Raju Easwaran. So if you have your questions, please type them in the chat box so that I can ask those. I'm sure there aren't many questions because I wonder what is left. It's been so well covered by you, sir, and Dr. Easwaran that even I am struggling to think, was there any aspect which was left untouched? But a thing which occurred to me regarding acetaminophen and its usage, especially when we are talking about chronic pain, the duration of use. Is there a limitation? I know that as long as the patient is using 3 grams or less per day, there is no issue. I remember from my Goodman-Gilman days, 4 grams and above for 10 days or more used to be, really hepatotoxic. But then today with the lower dose being used, so how long can one really use or continue to use paracetamol? Because, osteoarthritis is not going, rheumatoid is also not going anywhere. And the patients will continue to have pain and stiffness in certain cases. Yes. So how long can we use, safely use?
Ishwar, you want to take or I will take?
Sir, I'll speak after you, please.
Okay. So basically, I'm one of those person who keep on telling that it is not the drug finally that's going to be an answer. Drug is an adjunct to the rest of the treatment. And so to my patients, I keep on telling them, number lifestyle management, ensuring that regular exercises and strengthening of the muscles that are required, whether it's for the back or for the knee, number 1. Avoiding certain kind of activity which would help them, and also get into a fitness mode. Obesity, one of the major issues, we tell them that every 1 kg coming down would ensure that there's so much percentage of pain would also come down. And to ensure that the pain medications are taken only for a short duration of time, and maybe we can start all over again. But anything long-term is something which I don't really approve of, because I wouldn't take it. So I don't expect the patients to do that. Okay. However, yes, for the first 10 to 15 days, we would tell them to take it. And then after that, we watch for them and say SOS, and then go further. Despite the fact that these drugs seem to have very less side effects. I would still like to go a natural way rather than an unnatural chemical way.
I would I'll wholeheartedly second what Sir has just said. And this is exactly my practice. I will encourage them to exercise, and I'll tell them that exercise and all the medicines will actually work in the same way by releasing endorphins. The only difference is that medicines will instantly, while exercise will take much longer. And I do counsel them that if you are at a point where you need a pill daily, at least for osteoarthritis of the knee, you are probably far better off considering a joint replacement or some kind of a surgical intervention rather than just dragging on with the pill forever. For other kind of pains, complex pains like back pain, etc., I am very happy to send them to pain specialists or to dedicated spine surgeons if they need the pill for much longer time than what I anticipate.
So what I gather, sir, is basically 15 days at the first go. And with the adequate relief, then maybe SOS as and when it is required. That is what is your recommendation for chronic pain, right?
Yes. One of the things is today I had one 85-year-old gentleman who had come with knee pain, and he's saying he's doing all kinds of yoga activities, sitting on the floor, doing puja, everything absolutely. When I got an X-ray and look at his knee, the joint is totally worn out, absolutely. And I was amazed at the fact that with that joint, he's still doing all kind of things. But he just kept on saying that I get occasional pain, otherwise I'm doing everything that is possible. So I think a lot of time we get carried away by the X-rays, a lot of time with the MRIs that are there. It is very, very important for us to understand that both the things do not match at all times. Sometimes when you have patients with so much pain and symptoms, you look at the X-ray, there's hardly any changes. Well, there are a lot of people with tremendous amount of X-ray changes, but the symptoms are nothing. So I think another thing is this 83 fellow tells me, sir, you might tell me surgery, which is a lot of people. I said, I won't tell you surgery till you say that your quality of life has been disturbed. Okay, because the quantity of life, it is not in our hands. The quality of life, we can give it in case you suffer from pain. So that's the storyline that is always there. And if they all these medications can give them freedom from pain for a certain period of time, why not? That's what I would look at.
How about, sir, because when we talk about comorbidities in patients, yes, we understand that in diabetics and cardiac patients and some other patients, and especially where NSAIDs, in terms of hypertensive NSAIDs, are not very considered very safe. These can be used in these patients also. In patients of chronic illness, there is a degree of fatigue. It sets in, because of the illness, because of changes in the medications. Many times the medications are not working, and so on and so forth. So there are behavioral issues, and pain does bring about a set of anxiety and depression with it. With the central activity, many patients using acetaminophen, they tend to feel sort of happy and relieved. I don't know, it's a placebo effect. I know when we talk about pain, a lot of people are placebo responders as well. But because of central activity, which Dr. Easwaran also emphasized on towards the beginning, and the high lipid solubility, do you see that that's somewhere, some activity there with paracetamol, which takes care of these two comorbidities as well?
It does, and I think the cannabinoid mechanism is the logical explanation, and particularly if you combine it with caffeine, which can be very easily done by swallowing it with a cup of filter coffee. It increases the passage of paracetamol, it increases the absorption, and it increases the speed at which it is transported through the blood-brain barrier. So I think I've now come to accept that paracetamol, just like gabapentin, pregabalin, etc., acts purely on central basis with very limited peripheral action, if at all.
So yes, because many patient, and I have seen it. It's a relief, and many a times, honestly speaking, talking about the dosing, I have taken the ibuprofen and 325 combination of paracetamol. It didn't give. So frequently I felt that, okay, why not I add one more 500 to it? So actually it becomes a sort of a, 825 plus whatever is ibuprofen. And that really helps, because sometimes I felt that 325 is just not adequate. Yes, there is a reason for concern, as is with any medicine, but somewhere I feel it's a overreaction of ours, because I wonder how many patients with really paracetamol toxicity have we seen. A quick comment.
I'm told it's a very popular method of committing suicide in the developed world. So
Yes.
I was reading in a journal article that in a country like America or UK, they are not going to give you more than one box of paracetamol at least. So I was very surprised, because even in my residency at Maulana Azad Medical College, we've seen a lot of hepatotoxicity, but none due to paracetamol. And I think it was N-acetylcysteine as an antidote was kept in very few places in Delhi, in RML Hospital and Maulana Azad Medical College and All India Institute of Medical Sciences. It's not a very easily available molecule. But Dr. Shetty, sir, what is your experience? Have you seen a paracetamol-induced hepatotoxicity, or heard about it being spoken by your medical colleagues?
Yes, I think in my whole thing, I have seen about 2 patients who have gone Stephen kind of a syndrome that they've gone through. And one of the things that they attributed, it could be because of paracetamol. Though personally, it is not my patient, but it happened to be seeing them because as a part of the hospital requirement, and we're looking at mortality and morbidity meeting. That was one of the things that was highlighted, that lot of people probably do not realize that there are some patients who can get into this thing. So we need to be careful, number one. And more important than that, I think as clinicians and as orthopedic surgeons who are busy practitioners, we do not get LFT done for most of our patients. And I would recommend that as we get the blood test done, in every comorbid condition, let's get the liver function test done and look at that data. I mean, you don't have to send everyone to a gastroenterologist, but let's look at it. And if you think that is okay, then we also know that the kind of dosage that we're talking about today, a BD dosage of 1,000 milligrams spread with a maximum of 2,000, I think we should get in a good deal. That's what I would look at.
That's a very good message, sir. And it's a simple test that we can order with a few strokes of our pen. And I think a lot of our patients, especially male patients, may actually be regular daily alcohol consumers, whether they want to admit it or not. And this can probably be an eye-opening thing for them as well. And we should probably be a little cautious in prescribing paracetamol to perhaps this group of patients if they have established derangement of liver enzymes like gamma-glutamyl transferase, etc.
Yes. I think until this exercise of us sitting together and discussing, I think we were not too bothered about liver toxicity until we read through it. And what we read, I think I want to pass on to my colleagues and said, listen, we use it indiscriminately without a doubt, no question about it. For a simple reason, we think it is less nephrotoxic, less GI toxic, and less cardiac toxic. But sometimes when you go through all the literature that are there and when it gives a message, we wanted to pass it on to us. And this is one of the things that would think, yes, paracetamol is a safe drug among all the NSAIDs that we are talking about. And yet it has got one issue. Let's take care of it by getting the test done before starting them on medication.
Yes, sir. I do remember, and as Dr. Raju Easwaran mentioned, MAMC, we used to have a lot of talk about N-acetylcysteine, but and in pharmacology because of obvious reasons. But somehow we had never seen any usage there. But having said that, and since we have touched on the hepatotoxicity with paracetamol, I know you have pointed it out during the deliberation also, but I was reading elsewhere some time back. It's a reason for concern. But should we be running scared? In sense, is hepatotoxicity, should it be an absolute contraindication for the use of paracetamol? Or The grade wise, we should look at, yes, we permit up to a certain level, certain extent. I believe Dr. Easwaran mentioned that not to go beyond 2 grams in certain situations. Should that be the case, or should it be an absolute contraindication?
I feel for orthopedic community, it should be a relative contraindication. We should immediately send the patient to a hepatologist, because not only a deranged liver, so these patients may have high BP, they may be on loop diuretics. So sudden hypovolemia or a hyponatremia, I mean, these things we are very ill-equipped to deal with. We probably won't even know if a patient is hypovolemic or hyponatremic. Now that can precipitate a hepatic encephalopathy. And the problem with N-acetylcysteine is that unless you give it within 24 to 48 hours of liver damage, it is probably not going to work, because your molecule has already covalently bonded and screwed up all the liver cells. So I think as an orthopedic surgeon with all the comorbid condition, we probably are less equipped to deal with this. We should just give one visit to the hepatologist, let the patient be treated by the hepatologist, and let the pain medicines be then monitored by the hepatologist.
Yeah, I think I will second what Easwaran says. In patients who are known patients of any liver damage, I think we need to do it with a lot of caution. In patients whom we do not know or do not have it, let's get it tested. In a world of medical activism where there are a lot of people who might ask you or may take a legal step, I think it's better to be safe. We're getting the legal by the liver test done and be safe. That's about it. And then we know that we are not going to give them more than 2,000 milligrams. So that's a very safe dose, and that's fine. I mean, that is the way to go, I think so. Being scientific, being practical, and also being very, very compassionate to the patient. I think that's the way.
There are, I think, no more questions which are coming our way. So I would quickly request you to final words on paracetamol 1 gram. If I don't know if I've left anything, you have not covered anything, but yes, the final place in therapy in the management of chronic.
Well, if at all we can get a drug which has got only a sustained release where we can utilize it once a day, nothing like it. I would love to have that because that means we are reducing the frequency of the drug being taken. Number one, and it's over an extended period. That's the way to go about. This is what I would think should be the best way to it. And tomorrow, sometimes a lot of people with patches and all this thing, if at all we can get across to it, other way of doing things, So I would think that's the way to go.
Thank you, sir. Dr. Easwaran.
From my perspective, as orthopedic surgeons, we must be wary of the power of compounding. NSAIDs or any medicines which are used regularly for any chronic conditions can compound into serious problems for our patients. So I feel that simpler molecules like paracetamol, particularly if available in extended release preparations, would be my go-to choice for moderate intensity pain. Of course, severe intensity pain might require different molecules, but at least for the common OPD pains that we come across, in an adequately worked up patient, we should probably look at paracetamol as an exciting new molecule, new in the sense that the extended release variation, probably if it comes in a smaller size pill, which is easier to swallow, it will be even better, an icing on the cake.
Thank you so very much, Professor Shetty, for joining us. Thank you so very much, Dr. Raju Easwaran, for such a candid and succinct deliberation. We loved it all. I think we have run out of time and the questions as well. You made things very clear and put them in the right perspective. I thank you on behalf of my organization, Pulse Pharmaceuticals. And also I take the opportunity to thank OrthoTV for helping us host this webinar, this session today. With these words, I'll be signing off, ladies and gentlemen. Thank you for being a great audience. And I hope you have enjoyed the deliberation. Thank you so very much.
Yeah, thank you one and all. And thank you, Easwaran, for being such a great partner for this evening exercise.
Thank you, sir. Thank you for your magnanimity. Thank you very much.
Thank you. Yeah.
Over to you, Poonam. Poonam, OrthoTV. I think, sir,
we can. They would have gone for dinner, I guess. So don't worry.
yeah, it's too early for a makeup. Yeah.
Right. So,
Thanks, sir.
we'll sign off. Okay.
Yes,
Bye.
we sign up, sir.
Bye.
Yes.
Bye.
Bye.
Good night.